So 55 years ago, an English anesthesiologist named Ian English wrote up the technique for internal jugular vein technique, right? But in 2024, we don't have to do it his way, right? So this is a paper from a famous hospital in New York City talking about basically what I'm talking about, quality improvement in vascular access. I probably have 15 minutes to go. Stick with me, you know, I'm doing my best. All right, but their analysis in this paper said that their CLABSIs were most frequently associated with internal jugular vein access, right? So for me, I would do something different. That's how I roll. Like, oh, you having a problem? This isn't working out for you? I would do something different. But no, they went on to explain why they used it. Their data showed that it had a higher infection rate, but they're going to tell you why they use it. And this is the reason in the famous hospital why they chose the internal jugular vein. Number one, their patients are sick. Now, at the height of the viral epidemic, every night their ICU was on TV, national news, and their patients look very sick. They're no sicker than your patients. You know what I mean? And like, I don't give sick patients an increased risk of infection. They already, just by being sick, they have an increased risk of infection. I give them a minimal risk of infection. Just that's the crazy way I think. The second reason was they do the jugular vein because they're training residents. And I always say, if anybody has a weapon, I want you to end my life right now. I don't want to live. If this is the reason, you're going to train people to do the wrong procedure because they're residents. Like when I train residents, and I've trained many, probably as many as anybody in this country, they have to learn how to do it my way. I would no way teach them some way that I didn't, anyway. And the third reason that they use the IJs, the subclavian, is not easy. Now it's the axillary vein, we'll get into that. But yeah, they're right, it's not easy until you learn how to do it, and then it becomes pretty easy, right? So I was at that institution, and I was going to, you know, view what was going on there. And this is one of the patients we got to see. 72-year-old guy with Clostridium difficile colitis. He did not, they wanted to give him TPN, he did not have chronic kidney disease. So what would be an acceptable vascular access device for a patient like this? So, a PICC line, probably a multiluminal PICC line. A tunneled IJ line where you tunnel out to the chest fine. One of my axillary vein catheters, depending on how long I thought he needed the catheter. I would never put a catheter in the middle of his neck and direct it up. Never. You couldn't make me do it. And that's what they did for this patient. So basically, they got the assessment wrong. They assessed the patient for needing a central line, and then they gave him the wrong central line. So like, basically, you're hoping to get lucky. Once you assess it, once you get the assessment wrong, you're hoping to get lucky to prevent a complication. Right, so I'm there and we're going in to see the patient. I'm gonna watch the magic at the big famous medical center. I'm gonna show you the procedure at the famous New York City Medical Center. And all the things I put in titles, I don't agree with. This is how not, according to Dr. LaDon, this is how not to do an internal jugular vein procedure. What I do like about this is they sound like me. They've got this cool Brooklyn accent, but everything I put in titles I don't agree with. They start at the head of the bed. Where's it gonna be? Ear is bad, chest is good. Where's the dressing gonna be when you start at the head of the bed? They did use ultrasound. Otherwise, it's in English in London in 1969. We use micropuncture equipment. What the PICC team does, what IR does, we don't use that big 18-gauge needle just because somebody put it in the kit.
Okay.
Notice how close we are to the ear.
20 is 20.
You know, it's... I thought they were going to dilate without cutting the skin. But no, I don't cut the skin. You get much less bleeding if you don't cut the skin. Trust me on that one.
What do you call it? Bad patch? Thank you. Bias patch.
Let's suture it down nice and snug to really handicap the nurse that's going to provide 99% of the care and maintenance. There's a TPN line in a sick patient. Let's move the ear out of the way and put the dressing on. I don't use heparin.
nice work.
So I told the fellow nice work, I was being polite.